This particular group gets to hear my last slides. I got discombobulated a little bit uh, with time. For some reason I thought I had another 10 minutes, and I only had a few slides to go anyway. So let me finish what I was talking about, and then I'll go into the next presentation, which is really about the National Hispanic Latino Mental Health Technology Transfer Center. That's a mouthful because I'm kind of wearing two hats today. So we had talked about all of these barriers, and where I was going to end the presentation was, how do we break down these barriers that cause health inequities? And in reality, we're talking about really four different spokes. So it's a four-pronged approach: access to services, workforce development, community initiatives, and of course the policy domain, which is so important. So in terms of access, we have to increase access to healthcare, to behavioral healthcare. As I was saying, Latinos, Hispanics have consistently been the group with the least access to health insurance. And while they improved tremendously under the Affordable Care Act, sadly, that's not really been the case in Texas. So we have to continue to push, and I'll return to that point in my last slide when I talk about policy. So expanding Medicaid, expanding access to the Affordable Care Act. I think if our colleagues on the right side of the political spectrum had spent their efforts, invested their efforts in improving and fixing the many challenges with the Affordable Care Act over the previous four years, rather than trying to repeal it and do away with it, we'd be in a different place right now. The Affordable Care Act is not perfect, but it's a step in the right direction, and the problems that it has are fixable. In terms of increasing access, we need to promote education and training so individuals can actually move to better jobs, better employment with better benefits. Large numbers of Hispanic Latinos that have lower levels of formal education end up in entry-level jobs that have little or no health benefits. So if we promote education and training, people can then move to jobs that are higher paying and that come with better benefits. We have to continue to embrace SAMHSA's no wrong door into treatment philosophy. And what that means is that no matter where you come into contact with the provider system, all of your needs are going to be attended to. If I go in to my primary care physician because I'm experiencing some physical problem, they're also going to screen and assess for substance use, for alcohol use, for other types of substances, and if some red flags emerge, they're going to actually facilitate my entry into treatment there, connect me with a provider. And there's different levels of connectedness from, here's a little piece of paper, call this place and make an appointment, which we know doesn't always work, to actually helping to navigate somebody into the treatment that they need, which social workers are really great at doing, and vice versa. Somebody is in a mental health or substance abuse clinic and they have medical issues. We screen for those, we ask about that, and we connect them with primary care or specialty care as needed. That's what this no wrong door into treatment philosophy is about, and SAMHSA has been really pushing that for a couple of decades. And then we have to create welcoming environments in our clinics. It's great, we make all of these efforts to get somebody through the door, and then they come through the door and they don't feel welcome. The person that receives me at the front desk not only doesn't look like me or doesn't speak my language, but they may be unfriendly, right? We often forget that our frontline staff are the first contact with our clients and with our patients. And we have to invest more in training them on delivering good customer service, at being welcoming and receptive, and always having a smile, and always being ready to ask whatever question it is asked. But it also goes beyond that. We don't think about the pictures, the decorations that we have in our waiting areas, in our clinics. I often share a story that when I moved to Houston in 2008. My daughter was then 4 years old, and I asked around my colleagues for a pediatrician, and they sent me to this pediatrician who was incredibly highly recommended, and the guy was incredible also as a provider, as a human being. We're still friends to this day. But I'll never forget that when I went into his office, we went together, my wife and I, and our 4-year-old daughter, and there's my wife is 6 feet tall, there's and thin as a rail, right? And I'm a short, fat Puerto Rican. So here is this tall, statuesque African American woman and this short, chubby Latino man, and sticking out like sore thumbs because nobody in the waiting area looked like us. But on top of that, we looked at the gorgeous oversized pictures of children in the pediatrician's office, and all of these children were blonde, blue eyes. I mean, there wasn't a single kid on that wall that looked like our daughter, our beautiful, a Latina daughter. And so, and I took notice of that. Now, being the person that I am, and I don't rush to make judgments about people, it didn't make me leave, or it didn't make me not want to be there. But when the time was right, after I had developed a relationship with a pediatrician, I actually made a comment about it to him. And to his credit, he acted on it. He diversified the pictures that were on the wall of the clinic, right? It's something that he just hadn't thought about before. So that's what I mean by a welcoming environment, a place where I feel like I'm wanted, like I'm valued, like they've taken the time to learn about who I am and where I come from. The materials that are there for me to read are the magazines, all just in English, in a clinic that sees a lot of Spanish speaking patients. We have to be mindful and pay attention to those things. Workforce development is the second area. And this is just some examples of how we increase access. Workforce development is another one. That's what this particular presentation is about. That's what the Hispanic Latino Mental Health Technology Transfer Center and the entire Technology Transfer Center network is about. It's about workforce development. I'll talk more about that in that next presentation. We have to increase the number of Hispanic Latino practitioners. No question about it. We have to create more educational opportunities so folks from Hispanic Latino communities can become providers. But as I said earlier, the Latino population is going to continue to grow much faster than the ranks of Latino providers. So we also have to increase the number of providers who are not Latino, who are not Hispanic, but who can practice in a culturally grounded and linguistically proficient manner, right? You don't have to speak Spanish to work with Latino clients. I mean, there are interpretation services, for example. I've known colleagues who were not incredibly proficient in Spanish, and then they managed to get by. I was in a mental health clinic. I was a psychologist in New York many years ago, and together with the director of the clinic, we did a study of no-show rates. We were, no-shows are very expensive because you block times for patients that then don't show up, and in the meantime you have a long waiting list, and you're not able to bill, obviously, because they didn't show up. So we launched a study of no-show rates before the director just wanted to start double and triple booking, and we said, well, we can't jump to that without really trying to figure out what's accounting for the no-show. And so we did a clinician by clinician study, and I'll never forget, one of the most striking things that we found, there was this bilingual, bicultural psychologist in the clinic. This was in the South Bronx, by the way, who had the highest no-show rate of all the clinicians. And it didn't make any sense at all. And then there was this was a young woman, incredibly well-trained, highest no-show rate. And then there was this older Jewish gentleman who spoke very, very choppy Spanish, and he has the lowest no-show rate. So almost all of his patients came all the time. Very few of them missed any sessions. And then we started to get to the bottom of it, and we interviewed some of the patients. We did some customer surveys, customer satisfaction surveys. And what emerged was they had very different ways of interacting with and relating to the community. The young psychologists had been trained in a psychodynamic format in Argentina. And she was very cold. Well, the patients perceived her as very cold and very distant and not like me, even though she spoke my language, and they just couldn't relate to her. So they would go once or twice, and then they would not come back, or they would miss more sessions than they would make. And this older psychologist had lived in the Bronx for a very long time, understood very well the Puerto Rican and Dominican communities that he was serving, had this incredible cultural humility, where he asked lots of questions about things he didn't understand, fumbled through the language, laughed about his language mistakes with the patients, invited the patients to help him improve his language. It was a completely different set of circumstances, and it became very clear. And so we did some training for all the clinicians across the board, because you never want to have anybody feel singled out. And the rate of no-shows dropped significantly when we started working with clinicians on how to be more welcoming with patients, how to follow up with them. Another thing that this older gentleman would do is that when a patient missed, he would immediately shoot out a note. He would put a little card in the mail. I'm so sorry that you missed your appointment. I'm looking forward to the next one. Or he would make a call to the patient and leave a message, or speak with them if they were there, whatever the issue. And then when they came back, he made a big deal of the fact that they had come back. Oh, I really missed you last week. Hope everything is okay, etc. The other clinician with the high no-show rate, she felt, because of her training as a psychodynamically, psychoanalytically trained clinician, she had to kind of unpack what they had missed, right? And she made a big deal about the fact that they had missed, but not in terms of, I'm so happy that you're back, in terms of, it means something that you missed. Are you resistant to dealing with your issues, or are you in denial? And that just didn't resonate with the patient. So to me, it was an incredibly eye-opening experience as a young new clinician just starting on this journey. So that's about increasing providers, number of providers that can practice in a culturally grounded, linguistically proficient, and humble manner. Also increasing the number of providers that are trained in evidence-based, culturally grounded interventions that are either developed or tailored or adapted to Latinos or whatever minority community you're practicing with. It doesn't matter how wonderful you are, how welcoming you are. If what you're doing doesn't work and the patient is not getting better, sooner or later they're going to stop coming, right? So we want to make sure that we're providing treatment that works so that the patient is going to experience symptom relief and increase in functioning. And that requires more training. And then, of course, one thing that we've learned over the last year and a half with this COVID pandemic is that telehealth has tremendous uses and advantages. So we need to continue to increase telehealth options, both training providers on the use of telehealth and making it available for providers and for patients. So that's in terms of workforce development. And then in terms of community initiatives, we got to talk about behavioral health with our communities. We have to increase community conversations about behavioral health everywhere and normalize the experience in our schools, in our elementary, middle, high schools, community colleges, universities, in our community-based agencies, in our faith-based settings. We have to talk about mental health and educate the whole community about mental health issues and learn about what perceptions or ideas the community may have about why these conditions happen and their feelings about treatment, and just talk openly about it, educating communities about signs and symptoms. One of the things that I did in Houston the year before I moved down to the Valley, so 2 years ago, with a grant from the Evangelical Lutheran Church of America, the ELCA has a mental health program. And with a small grant from them, we actually trained clergy, lay staff at several Hispanic ELCA churches, and the overall community on talking about mental health, on red flags that somebody might be developing a mental health problems, and how to refer them. We spent a lot of time working with clergy on how they can't be all things to somebody. You can't be the person's pastor and be their family therapist and be their individual therapist and be their couples therapist, right? But you can recognize that they need help and connect them with a place where they can get help, right? So educating the broader community about when somebody might need help and where to go, where to refer them. In normalizing all these conversations, we are combating stigma and discrimination. And of course, these messages have to be culturally tailored to the population. And then the last piece is policy. You know, in social work, and many of you this morning put in the chat that you were social work professionals. You know, in social work, we may actually train micro and macro practitioners separately, but we believe that you practice in an integrated manner, and we got to attend to policy. And there's just four small pieces on the policy side. We have to continue to make efforts to disaggregate data. You know, the data that's come out about the racial disparities, racial inequities, and COVID on their own are remarkable. They're even more remarkable when we realize that we don't have all the data, because in many places they weren't capturing race and ethnic data at the time of death, for example. So I suspect the picture is a lot more dire than what we see. And you know, in terms of reporting across the board in all types of service setting, we should be disaggregating data better so that we can really tailor interventions to specific groups. We need to exercise flexibility in treatment policies and payments, particularly in places that have really high rates of uninsurance, like Texas. We need to be using navigators for federal stimulus opportunities. Every time the Affordable Care Act opens, enrollment periods open, the federal government funds navigators to help people get enrolled and learn more about it. Again, with the previous federal administration, this was almost completely shut down because they were trying to kill the Affordable Care Act. It's now coming back in full swing, and many private not-for-profits took this role on in the previous 4 years. And then we have to continue to expand and provide flexible coverage for telehealth. In Texas, one of the great things that the legislature that just wrapped up did was actually expand telehealth options. So that's a step in the right direction. So we are capable of getting it right, and we do many times. So that's that presentation. And then I want to switch over to, if you give me 1 second, if anybody has any questions while I shift gears, just please open your mics and just jump in. All righty, this is the right one? Yeah. So as I said, I am wearing 2 hats today, and one of them is representing my colleagues from the National Hispanic and Latino Mental Health Technology Center. They do a phenomenal job on all the things that I'm talking about, and we thought this would be a good opportunity to do a little bit of dissemination so that people know who they are, know what they do, and partner with them, reach out to them to request services, trainings, webinars. Everything they do is at no cost to the recipient because they are funded by SAMHSA, the Substance Abuse and Mental Health Services Institute. So they are in Puerto Rico at the Universidad Central del Caribe School of Medicine in Bayamón, Puerto Rico, at the Institute of Research, Education, and Services in Addiction, IRESA. So IRESA has been working in this area of workforce development for over 20 years. I mean, they were the Caribbean Basin Addiction Technology Transfer Center for a while. Then they were the National Hispanic Latino Addiction Technology Transfer Center for 10 years. And then when SAMHSA funded the new mental health technology transfer centers, this is the third and newest group of TTCs, they were selected to be the National Hispanic Latino Mental Health Technology Transfer Center because their expertise in workforce development or technology transfer. So I'll talk a little bit about the SAMHSA's Technology Transfer Center programs, which is a remarkable initiative paid for by our tax dollars, and then specifically the National Hispanic Latino Mhttc, and then a little bit about why we need a national center. I won't spend too much time on that because I think that's become clear from my previous presentation. So the Substance Abuse and Mental Health Services Administration, which is part of the Federal Department of Health and Human Services, has a technology transfer center program. And again, I told you about my obsession with language and precision, so I'm not going to assume that we all know what I mean by technology transfer center, and I'm going to talk about it. What SAMHSA calls technology transfer is what most of us would call research to practice. So the formal definition of technology transfer is the transfer of a new technology from the originator to a secondary user. This is especially the case in large-scale initiatives where technologies are transferred from more developed countries to countries that are under development in an effort to boost their economies. In our field, healthcare, behavioral health, technology transfer, as I said, is meant to signify research to practice. And these technology transfer centers, or TTCs, develop products that are based on the latest research, and they disseminate them broadly to frontline workers who may be less likely to read scientific journals or to go to scientific conferences, right? When we were in training as undergraduate students or as graduate students, we all had access to the library and lots of journals, et cetera. But that access is one of the first things that we lose when we graduate, right? And it's expensive for our universities to continue to provide us access to the library, so we just don't have the access. And then the truth of the matter is that conferences are expensive, and many of us just don't have the resources to go to conferences. So the TTCs really repackage the findings from research as written products, as webinars, as conference presentations, and they make sure that this gets to end users. So SAMHSA has 3 networks. The oldest one is actually the Addiction Technology Transfer Center network. The Prevention Technology Transfer Center was the second one developed. And then, as I said, the MHTTCs, the Mental Health Technology Transfer Center, is the newest one. Each of these 3 networks has a national coordinating center, 10 regional centers, 1 in each federal region, and then 1 American Indian and Alaska Native Focus Center, and 1 Hispanic and Latino Focus Center. The ATTCs, the addiction ones, support national and regional activities focused on preparing tools that practitioners need to improve quality of service delivery. And they also provide intensive technical assistance to provider organizations to improve their processes and practices, delivering effective substance use disorder treatment and recovery. And there is their website. Again, I'll share the slides, but you just Google technology transfer. Can you excuse me for one second?
Hi, folks. We think that we may have lost Dr. Torres. Please hold.
No, I'm here. I just have I'm working from home today. My wife actually goes to the clinics. She's been working from home through the pandemic, but she goes to clinic on Thursdays. And she asked me to stay home today because we have a repair person coming. So I apologize about that. So this is the ATTC. And of course, Simon. Thank you. You try to plan for every contingency, right? The second network, as I mentioned, is the Prevention Technology Transfer Center that again is focused on prevention science. And then the one that's one of the co-hosts of this conference today is the Mental Health Technology Transfer Center. Is the Mental Health Technology Transfer Center. And again, they work with organizations and treatment practitioners involved in delivering mental health services to strengthen capacity to deliver effective evidence-based practice, particular focus on Latino communities. And their link is there as well. Just give me 1 second. I'm gonna put the dog in the backyard because he's not gonna shut up. I don't know what our pets are going to do when we all go to work back to the office full time. So what I wanted to talk to you a little bit today is about specifically the National Hispanic Latino Mental Health Technology Transfer Center. They are one of the hosts of this organization. They are a key subject matter expert and a resource for mental health and school mental health workforce across the US. And their job is to ensure high quality services, effective mental health treatment, recovery support services in mental health, and implementation of both evidence-based and promising practices. So they are, as I said, located in Puerto Rico, and they are part of, it's not it, oh, here's a network of mental health technology transfer centers. As I mentioned, with all the TTCs, there's one in every federal region. Of course, our mental health technology transfer center is our colleagues at the Southwest Mhttc, which is at the University of Austin. They also have the Region 6 Addiction Technology Transfer Center, which is one of the co-hosts of this event. And then the National Center is in Puerto Rico. So they work across the entire United States, and they work with all the regional mental health technology transfer centers and with the coordinating office, which is in California. It's an incredible resource. You know, just like I was talking about, patients sometimes don't know what services are available or where to go. Providers sometimes don't know how much is available out there in terms of technical assistance and training to improve their provider workforce. And as I said earlier, at no cost to them, because this is federally funded. In terms of some of the products that they've developed, this is just a sampling of the products that they developed. They've developed some products with for Latino indigenous populations, so providers that are working with folks from indigenous communities, from Maya communities in Guatemala to Mexican indigenous families, or folks from other indigenous groups in the Northern Triangle of El Salvador, Honduras, and Guatemala. And so we recruit experts on different topics throughout the country to be part of our training pool and our development pool. And I am actually part of the advisory board. And in addition, I'm one of their trainers from time to time. They also develop, and these products are all available at no cost from the website. They also develop products in terms of specialized topics. And there you have a sample of 3 of them: gender violence among Latinas, trauma-informed care for immigrant, Hispanic and Latino clients, and stress management during the quarantine period. This was developed in the last year as a response to those providers that are trying to care for clients and care for themselves and their families during the pandemic. Again, all available from their websites. And then there are products that have to do with implementation science. And here's a sample of 3 of them. La Clave, a psychoeducational tool to reduce treatment delay in Latinx or Latino clients with first episode psychosis. As I said, we often delay seeking treatment, and by the time we come into treatment, it's more complicated. So trying to get into treatment early, early suicide attempts and culturally responsive approaches for Latinos. And there's the one on the right on complicated griefs. Again, these resources are available from the website at no cost. In addition, the Mental Health Technology Transfer Center does webinars throughout the year, and they actually do trainings with in partnership with organizations. In fact, when they were first funded 3 years ago, one of the very first organizations that we partnered with was with the University of North Texas and Eastfield College, which is one of your partners. So we were up in Dallas doing some trainings. Here's some examples of the activities that they do to engage with provider agencies. Remember, their clients are the providers, so that's you. Developing and delivering educational training events. These could be in-person, synchronous or virtual technical assistance sessions, webinars, all kinds of virtual and in-person activities. We help programs identify facilitators and challenges to implementation of specific practices. So if your organization is considering adopting a new intervention for the population that you serve, we can help you think through some of the challenges and some of the facilitators. A lot of capacity building on cultural elements and competencies that are often required by your funders. And of course, comprehensive training and technical assistance on a broad array of topics, from community health workers to school-based mental health services. This is the main contact. Dr. Ibis Carrion is the director of the center, and Mr. Angel Casillas is the project manager. I'm going to pause for a moment so you can write down Angel's email address, angel.casillas@uccaribe.edu. So if you want services from them, if you want to partner with the ATTC, you can just contact Angel and he can get the ball rolling on that. And again, if you just Google the Mental Health Technology Transfer Centers network, you'll get to their webpage. I'm being mindful of time. So that's who they are. And then I want to talk a little bit very quickly about why do we need them? Why do we need a National Hispanic Latino Mhttc? So I talked a lot about health inequity in my keynote presentation, but I didn't really talk about Hispanics in general. And I don't know if any of the previous presenters have talked about the Latino population. So I wanted to spend 10 minutes talking about them and then just open it up for a conversation. So one of the reasons is just the sheer size of the population. Right. So right now there's almost 61 million people in the US who identify as Hispanic or Latino. That's almost 18% of the population and projected to grow to about 30%, almost a third of the US population in the next 15 years. Right. So in terms of the size of the population alone, it's important that we have an organization that helps us focus our services to that particular community. I'm going to skip through this. I want to go to I'm going to skip to this. Some of the challenges that I was talking earlier about Hispanics and Latinos versus non-Hispanic whites, challenges and strengths, by the way. So characteristics of the population. So the age of the population is a strength. The age of the population is a strength. So Latinos as a group are the youngest a group in the United States. The median age for Latinos is 29 years of age versus 43.5 for non-Hispanic whites. As a challenge, we have lower educational attainment. So on folks 25 years and older, only about 31% have a diploma, high school or college or higher, versus 7% for the non-Hispanic whites who have no diploma. I'm sorry. Okay. Okay, thank you. So lower educational attainment, lower individual median income. So the medium household income, individual income for Latinos is about $26,000. For non-Hispanic whites, about $38,000. So I don't know about you, but I could do a lot with another $1,000 a month, right? Higher poverty levels, I talked about this earlier. Less health insured, I talked about this earlier. And then the language can be a barrier. So Latinos who speak another language, 71%, 72%, versus 5.5% non-Hispanic white. That's a strength, right? So that's a tremendous strength. Speaking more than one language is a strength in any community. Latinos that speak only English, about 28% versus 94.4% for the US population, the non-Hispanic white population. So these are just some additional characteristics. And why do we need the center? Despite the growth and the size of the Hispanic Latino population, challenges persist in terms of mental health and substance use service utilization across the board, from early detection and treatment to accessing evidence-based, culturally grounded interventions. And when you throw in the diversity, the tremendous diversity of the Latino population, things start to get really complicated. These are just some of the areas in which the Hispanic or Latino community has within group diversity. I'll touch briefly on these. Country of origin, the terminology used to refer to themselves, generational language acculturation, where they are in the US, and of course, race and education. Hispanics, I'm from 19 different countries in Latin America, plus Puerto Rico, who are a US territory, and of course from the US. There's many Hispanics in the US that will tell you they didn't cross the border crossed them, especially in the Southwest. Some folks from Brazil and Spain also identify as Hispanic or Latino. Not all do, but some do. All of these countries have different socio-political histories with the US and various social class distributions and racial and ethnic and linguistic backgrounds. And when people migrate, they bring all of this with them. So they're slowly acculturating and integrating into our society like all immigrant groups before them, but they still hold on to many of these things that they brought with them. In terms of terminology, I had talked about this in my first presentation. People use many different terms to refer to themselves: raza, Chicano, Hispanic, Latino, Latinx. There are those that hyphenate, Mexican American versus Mexican, Salvadoran American versus Salvadoran. The Pew Center repeatedly has found that most Latinos refer to their country of origin first. I'm Mexican, I'm Salvadoran, I'm Colombian, I'm Puerto Rican, and only secondary to a pan-ethnic label like Hispanic or Latino. And then the majority also have tremendous pride in being American as well. Many people will say, hey, I'm Mexican and I'm American. I'm Puerto Rican and I'm American. So that it doesn't, the fact that you identify with your country of heritage or one of your countries of heritage doesn't take away your pride in being part of the US as well. Another way in which Latinos can vary is generation. And I talked a little bit about this earlier, the first or immigrant generation. the second generation, the third generation, and then the folks who have been here before this was even the United States. In Nuevo Mexico, in California, and Texas, it's not uncommon to talk with families who will actually say, we didn't cross the border crossed us. You know, our family has been here for generations, for example. Language, I touched on this a little bit. You have everything from people who are monolingual Spanish speakers who never learned English to people who speak multiple languages and everything in between. Bilingual Spanish-English, bilingual English-Spanish, monolingual English, people who speak indigenous languages. So you have to know your client. Which Latino group are you working with? They vary in terms of acculturation, from folks who have very low levels of acculturation to the U.S. society, to folks who are, you know, red-blooded Americans, meat and potato eating, who are American in every way that you can imagine, and then everything in between, right? They vary in terms of race. You know, when you look at the census definition, Hispanics can be of any race. So you have white Hispanics, Black Hispanics, Asian Hispanics, Native or Indigenous Hispanics, multiracial Hispanics, and then you have Hispanics who refuse to answer the question of race. You know, you ask race and they'll put something else, right? So, and everything in between. I have a colleague in California who is Mexican and speaks perfect Spanish. His parents are both from Mexico, but he's Chinese and he has a Chinese last name. And people always are stunned when they speak with him and he responds in this perfect Mexican Spanish, and he tells them that he's Hispanic. People is like, you know, at some level, people know Hispanics can be of any racial background, but it sometimes stuns them when they meet a Hispanic that doesn't conform to their view of what a Hispanic is. Hispanics vary in terms of geographic location, where they are in the US. West Coast versus East Coast Hispanics, Midwest versus border communities, they're different. They come from different places, right? If you go, for example, to Florida, you're gonna find more people from Cuba, more people from Cuba, and in the Panhandle, and particularly a large Puerto Rican community, which is a relatively recent phenomena. In the DC, Maryland area, you're going to find large numbers of Salvadorans. You go to LA, it's people from El Salvador and from Mexico primarily. If you come here to the Valley, it's mostly Mexican American, and the Central American community is starting to increase. So it's different. So people say, oh, I work with Hispanics. Well, depending on where in the country you're located, you're going to work with different groups of Hispanics. In Chicago, for example, the two predominant groups historically have been the Mexican community and the Puerto Rican community. If you go to Georgia, North Carolina, South Carolina, there's huge Dominican communities that have moved down from the New York City area. And you have towns in Georgia and South Carolina, for example, that overnight had almost no Latino communities, and all of a sudden they're 10%, 12% Hispanic, and no services for those communities. So that the localities are catching up to the explosion of the population. And that's why we need centers like the National Hispanic Latino Mhttc. That's just a graphic. Some of you have seen them about where the Hispanics are across the country, the 10 states with the largest Hispanic numbers. California, of course, the first, and Texas the second, and then Florida the third. But you look at Illinois up there in the middle, you look, of course, New York up there, number 4, etc. I am,
Dr. Torres.
yep, I'm gonna stop and
Thank you.
open it up for questions. Let me stop presenting, if I can figure out how to do this. There you go. So any questions, comments, anything you want to share, anything that resonates about what I've shared, or
And we have just a couple of minutes before we have to conclude.
yeah,
Thank you.
you can put it in the chat too.
Ms. Holloway, do you mean what is SAMHSA? What does it mean? Substance Abuse and Mental Health Services Administration. I'm not sure I understand the question. SAMHSA is the Substance Abuse and Mental Health Services Administration. It's a federal agency that funds, among many other things, the technology transfer centers, and they're part of the Department of Health and Human Services. I'm going to put my email in the chat, and if anybody has any questions or wants a copy of my slides, I am happy to provide them. So thank you so much. It's a pleasure to chat with you. I know that this type of format doesn't allow for a lot of exchange, but I hope that we can cross paths again and continue this wonderful conversation.
Thank you, Dr. Torres, for this wonderful and informative information.
Thank you,
so
Ms.
much.
Nix.
You're
Have a
very
great day, everybody. Bye-bye.
Goodbye.